This is the second talk, completely different. As a surgeon, I get to talk about doing surgery and in what situation. So the title is Total Thyroidectomy or Labectomy for stage 1 thyroid cancer. And I would submit to you, it's not an either or, it's really a continuum of approach, and some people have actually suggested that maybe these patients, as we discussed earlier, undergo active surveillance, and some people have suggested they undergo ablative treatment. I am a civil servant, so I have, again, nothing to disclose. What I'm going to share with you is the outline of my talk and what areas I'm going to cover. What is stage 1 thyroid cancer? The staging actually is going to be different based on the age cutoff in the upcoming AGCC staging manual. And I think what's really important when you're selecting what extent of thyroidectomy to do is to accurately stage the patient before you embark upon thyroidectomy. And then I'll cover a fair amount, all of the different guidelines and at least my personal misgivings of the guidelines, because I truly do not think they're evidence-based. And then discuss with you options of when I would do total thyroidectomy versus a lobectomy, and of course the advantages and disadvantages. What I have up there though is a saying in American culture that the crime, that is stage 1 papillary thyroid cancer, that it really the punishment has to fit the crime, and I think it's very appropriate for this low-risk type of thyroid cancer. So what I'm specifically going to address is papillary or differentiated thyroid cancer. Within that is going to be histologic variants. I've always found it odd that a patient you heard earlier that's younger than 45 might have distant metastatic disease cannot do any worse than stage 2. So I would say, though, I think for a younger person with lymph node involvement, I would do a total thyroidectomy. That's the only reason I have the staging up there, because I know many of you are familiar. So what I'm really going to address is the solitary thyroid nodule in a patient, whether they're 45 years of age older or younger. And then within that, I think we need to distinguish, when we say stage 1, patient, as you heard earlier today, that has papillary microcarcinoma, that's a primary tumor of less than 1 centimeter, God forbid somebody put a needle in it, versus those really, I think, the stage 1 patients that have tumors 1 centimeter to 2 centimeters in size with no clinical lymph node metastasis or distant metastasis. Before I go into this, I meant to do this at the beginning because it was quite interesting today at the opening remarks. I think you had mentioned what Quan Du had asked the audience, and I actually wanted to do that because I could go for total thyroidectomy or I could go look for a lobectomy myself. If you guys were referred a 45-year-old woman with a 1.5 centimeter, that is just a solitary thyroid nodule. Cytology shows classic papillary thyroid cancer. Ultrasound shows no lymph node involvement. How many of you would recommend a lobectomy to this patient? Okay, I guess I should just get off the stage then. How many would recommend a total thyroidectomy? Okay. I have an uphill battle. Okay, so what is stage 1 disease? Why is it important? I think you already heard the epidemiology. This is the group of patients that are ever expanding. Perhaps it's a non-question to this audience of what treatment patients should get. I think a principal important point, perhaps some people that argue for total thyroidectomy, is that you never know the accurate stage of the patient when you see them in the clinic until they've had an operation. And at that time is not the time you're deciding on what extent of thyroidectomy to do is. So for those people who argue for total thyroidectomy, that's something that they've always held that near and dear. I say this because one of my mentors, colleagues, is Orlo Clark, who's been an advocate for total thyroidectomy his entire career. Well, what has changed in that intervening time is, I thought how Dr. Lee nicely outlined, is the resolution of ultrasound is dramatically better, where you could perhaps risk stratify and at least have an idea preoperatively what stage or extent of disease the patient has. As I already shared with you, this group of patients have had multiple extent of treatments advocated. There's quite a few groups in Italy and in Korea that are using radiofrequency ablation and microablation for patients with stage 1 papillary thyroid cancer. So staging is an important indicator of overall survival. I have different stages, systems that have been used, advocated by specific institutions such as Mayo Clinic with the AGE and Macy's, Blake Cady advocating the AIMS stratification system. They're all based on the age, the presence of metastasis, the presence of extrathyroidal invasion. And now we have a better idea of that preoperatively. So I think the old argument of you never know it's a truly stage 1 disease is less of a significant issue. Suffice it to say that all of these staging systems have been validated prospectively, but an important aspect of it is that they do not predict the risk of persistent and recurrent disease. Why do I say that? I think Dr. Sarah will probably address one of the reasons to do prophylactic central neck dissection is principally this. I've seen this just in my career time where my outcomes were outstanding, where not all of my patients were getting basal or stimulated thyroid globulins checked, not all of my patients were being interrogated by follow-up ultrasound, but in the last 10 years, the actual biochemical cure rate has dramatically decreased. So in a way, if you advocate lobectomy, you're not going to be able to use your basal or stimulated thyroid globulin to be worried about persistent or recurrent disease. Ultrasound would still be an issue. So how do you accurately stage these patients preoperatively before you decide what extent of thyroidectomy to do? I won't go into this in great detail again because Dr. Lee, I think, outlined nicely with those case series of what are the important imaging studies, what are the pearls and pitfalls. The pitfalls I learned a great deal from. So ultrasound really is imperative, and this is not only for the thyroidologist in the audience, but also the surgeons. They should be doing, or we should be doing, our own preoperative ultrasound and need to be skilled at it. What dictates whether you're going to do, in my opinion, a total thyroidectomy for a patient with stage 1 papillary thyroid cancer is, does the patient have a contralateral thyroid nodule? It also allows you to evaluate predominantly the lateral neck of the patient for suspicious lymph node metastasis. I do not think it's as great for central neck node metastasis, especially those that are posterior to the recurrent laryngeal nerves. Those are the scary ones to go back in and remove. So once you've stratified the patient based on the ultrasound, then you could decide if a patient has a solitary thyroid nodule, the question of whether to do a total thyroidectomy or a hemithyroidectomy. What is the role of preoperative ultrasound for staging these patients appropriately, determining if it's truly stage 1? One of the first studies was out of MD Anderson. They looked at their cohort of patients specifically for the reason I shared with you, where they were finding a lot of their patients having biochemical recurrence, elevated thyroglobulin levels, or an ultrasound showing a 4 millimeter nodule that's biopsied in the central neck or that is in the lateral neck. What they found is once they instituted doing preoperative ultrasounds, this is the surgeons doing it, that they were able to detect 20% of patients that either had a central neck lymph node metastasis or a lateral neck metastasis. Thereafter, in the literature, the group at the Cleveland Clinic, Mira Millis, has also found about 1/3 of patients that they're able to find additional thyroid nodules that need to be addressed, and some of these ended up being thyroid cancer, in which case a hemithyroidectomy would not be appropriate, and similar results of non-dominant thyroid nodules being discovered on the opposite side. So this really goes to show that the surgeons doing the preoperative ultrasound and stratifying those patients truly with a solitary thyroid nodule that's papillary thyroid cancer and determining if they're appropriate for hemithyroidectomy. I just have a quote here that I really like to emphasize, and I don't know how many of you do your own clinical ultrasounds. Maybe this is a moot point to this audience. Well, maybe it's not a moot point. So I really like this quote, and I think unless you start doing it and comparing what you find in the operating room and long-term follow-up, you'll never get good at it. I think you heard from Dr. Lee how it's really operator-dependent. Fortunately for me, when I was training, we were doing it in the operating room while the patient was asleep. So I have a quote by Weiss and Labectomy that says, "The ultrasound really should be like the stethoscope for a cardiologist. For any physician, both surgeons and endocrinologists, they really need to be using the ultrasound and evaluating these patients as part of their physical exam." All right, the third area I'm going to be talking about is what the guidelines say, what is the options and what are the data to support these options, and what is the advantages and disadvantages of doing a hemithyroidectomy or a total thyroidectomy. This is a really nice commentary about the many guidelines that are coming out by all of the European, Latin American, North American societies and associations in regards to thyroid nodule. The title, I think, summarizes at least what I think of it by and large. One should not just read what one believes. The nearly irresolvable issue of producing truly objective, evidence-based guidelines for management of differentiated thyroid cancer. I'm going to go briefly over what constitutes clinical evidence in different entities, not just the U.S. Preventative Service, but generally, high-quality data is randomized controlled trials. We don't have that for extensive thyroidectomy for differentiated thyroid cancer. The UK National Health System also uses the same thing. The highest level is randomized control or prospective cohort studies. And then lastly, the US Preventative Task Force, what they consider as level A is what outweighs in benefit to the patient as opposed to the risk of the intervention. Bob Udelsman did a nice theoretical power calculation, which helped us conclude almost 20 years ago, we're never going to have level 1 evidence of what extent of thyroidectomy to do in patients with differentiated thyroid cancer. Why? Well, if you want to look at complications, it's going to take more than 12,000 patients, 6,000 randomized to each arm. Recurrence, well, that's a more reasonable number of patients, 360 to 800, but you need to follow them 6 to 10 years. You throw in how different institutions manage and follow patients. That's probably not going to be realistic. And probably the most important reason when you're talking about doing an extent of thyroidectomy trial is overall survival. Well, that would take over 3,000 patients with 10 years of follow-up. And mind you, this was when we were not dealing with stage 1, predominantly papillary thyroid cancer. So forget it. You're never going to have level 1 evidence for us to make the decision of whether to do a hemithyroidectomy or a total thyroidectomy. So what do the different society and guidelines say? Well, the Japanese recommend that you should do really a total thyroidectomy for patients with high-risk disease. They've been doing hemithyroidectomy with ipsilateral central neck node dissection for more than 4 decades and have had outstanding outcome. The ATA, which I'll share with you the recently revised guideline, but in 2009, had suggested that really all patients should get total thyroidectomy, except for those patients with papillary microcarcinoma. Similarly, the British Thyroid Association would recommend total thyroidectomy, principally for those that had larger than 1 centimeter tumors, if it was likely to be multifocal, or if there was obvious extrathyroidal extension. And the NCCN guidelines, it's a collection of cancer centers in the US, also had very similar recommendation. Essentially, most patients should have total thyroidectomy, which is what the audience believes, as well as the ACE and AES. Well, in a span of, 6 years, the 2015 ATA guidelines have come out. Now, they recommend hemithyroidectomy essentially for most stage 1 papillary thyroid cancer, and even surveillance as a consideration for those that are less than 1 centimeter. Obviously, it has to be unifocal and intrathyroidal. The caveat of who needs to get a total thyroidectomy, obviously those patients with a family history. You might ask why. Very high likelihood, as you heard from Dr. Sipos, that it would be multicentric. Also, the false positive, rather negative rate in FNA biopsy in the familial setting is about 20%. And similarly, patients with radiation history are more likely to have multicentric papillary thyroid cancer. And obviously, those patients with suspicious lymph nodes. And then they recommend a hemithyroidectomy for those tumors that are greater than 1 centimeter but less than 4 centimeters. And clinically, no lymph node involvement based on ultrasound. Mind you, this is a strong recommendation of moderate quality. And then lastly, obviously, whether in your institution, in your practice, as a surgeon, it depends upon which endocrinologist is referring the patient to me. Is it an endocrinologist that is going to use radioiodine ablation, or is it an endocrinologist that's going to react to every thyroglobulin measurement, or is it an endocrinologist that is going to interrogate the lymph nodes and tell me there's something there? If that's the case, then I would do a total thyroidectomy if they're planning on doing radioiodine ablation, because clearly the thyroglobulin is more sensitive. And obviously, if the patient comes in, which oftentimes in the US happens, the patient comes in and tells you what they want done. So long as it's not unreasonable, I'll go ahead and do a hemithyroidectomy in some instances, or a total thyroidectomy if the patient really wants to reliably know they're biochemically cured. So why did the recommendations change? You know, just 6 years ago, at least for the ATA, it was recommending that total thyroidectomy in essentially every patient, except patients with papillary microcarcinoma. And now it's hemithyroidectomy, unless the patient has significant risk factors. So there isn't data, actually. It's not very data-driven. So this is the largest study done by Carl Billamore out of Northwestern. This is using a registry data in the US of over 52,000 papillary thyroid cancers. And when you look at it, even those tumors that were less than 1 centimeter had a low but significant shorter recurrence-free survival. And what's interesting is when he looked at it based on the extent of thyroidectomy, their overall survival for patients that had a thyroid lobectomy was significantly lower than those patients that had total thyroidectomy. So what happens was there was a follow-up study using the same data set with 10,000 more patients, and that initial study perhaps included patients that had other unfavorable features, patients with multicentric disease, the patients that had a tumor that was greater than centimeter and benefited from a total thyroidectomy were more likely to get radioiodine ablation and have some aggressive histologic variants. So Adams and colleagues, Julian Sosa's group, looked at the same data set controlling for those variables. And as you could see, there was really no significant difference between those patients that had lobectomy versus total thyroidectomy when you look at overall survival. And based on this, there was a move towards considering hemithyroidectomy as the treatment of choice. Lastly, I'm going to go through areas where are intangibles. As surgeons, we always don't know, and even as endocrinologists, when you're discussing what extent of thyroidectomy to do. So not all FNA biopsies are going to come back classic papillary thyroid cancer. In fact, many of them are going to come back indeterminate or a follicular neoplasm or suspicious for follicular neoplasm. A fair number of these patients are actually going to have papillary thyroid cancer or follicular variant of papillary thyroid cancer. So I thought I would discuss this group of patients. It's clear this patient is going to need a total thyroidectomy with a fungating mass as well as a therapeutic lymph node dissection. So how many of you see a patient with a thyroid nodule that's 2 centimeter that comes back a follicular neoplasm would do a total thyroidectomy up front or recommend that to the patient? Not many of you. Most would recommend a hemithyroidectomy? Precisely. So I'd like to cover, when I'm discussing extent of thyroidectomy, it's not only that initial thyroidectomy, where I would do a hemithyroidectomy in that patient, but at my institution, I think it's one of the only two institutions in the U.S., the Mayo Clinic does this. We process all of our pathology within 2 days and do the completion thyroidectomy in the same setting. So if it comes back as follicular thyroid cancer, I would recommend a total thyroidectomy unless the patient has only partial capsular invasion or minimal capsular invasion. So that's a patient perhaps we should consider doing total thyroidectomy as including what you would do a completion thyroidectomy for. The other is Hürthle cell neoplasm. How many of you dealing with a 30-year-old that has a 5 centimeter solitary mass that comes back as Hürthle cell neoplasm? How many of you would do a hemithyroidectomy in that patient? No. You all do total thyroidectomy? Good. Would you all do a prophylactic central neck node dissection on the same side in a patient with a 5 centimeter Hürthle cell neoplasm? Okay. So I would do it in a patient with a Hürthle cell neoplasm that's larger than a centimeter. I always do an ipsilateral central neck node dissection at the time of my diagnostic hemithyroidectomy because I do not want to go back into that central neck compartment if it ends up being Hürthle cell carcinoma. And for Hürthle cell carcinoma, as far as the completion thyroidectomy, I think it's clearly indicated regardless of there being only capsular or only angio invasion. The last part I'd like to discuss is many of the indeterminate FNA biopsies come back histologically as follicular variant of papillary thyroid cancer. In fact, I think it was a morning speaker who shared with us the rate of follicular variant of papillary thyroid cancer increasing, I think, both in the US and here in Brazil. So I think this is an important histologic variant to discuss what is the appropriate extent of thyroidectomy in these individuals, because most of them will show up with a solitary thyroid nodule and undergo a diagnostic, at least hemithyroidectomy, for the risk of cancer. So do these patients warrant a total thyroidectomy? A patient that is 50 years old with a 3 centimeter follicular variant of papillary thyroid cancer, that is solitary. This is the histologic diagnosis I'm sharing with you. Would you go back in and do a completion thyroidectomy or recommend a completion thyroidectomy? No. Good. I think my time, it seems like the practice pattern is very much the same, and I think we have very good data to tell us follicular variant of papillary thyroid cancer, the rate of lymph node metastasis is low, especially if it's encapsulated. There's a nice study done by Ming Zhao that included over 4,000 patients, and as you could see, the rate of recurrence for follicular variant of papillary thyroid cancer is significantly lower, besides the rate of lymph node metastasis being low. And the overall mortality is also much less. So this is a situation, if I have done a hemithyroidectomy in a patient, it comes back as follicular variant, the ultrasound already shows that it's only a solitary thyroid nodule, that I would only do a hemithyroidectomy for. This is just disease-free or recurrence-free survival by histologic subtypes, and as you could see, patients with follicular variant do significantly better than those even with classic or conventional papillary thyroid cancer. Of course, age is included in the staging system because the outcome of these patients is different, and that might be something that might sway you on whether to do a completion thyroidectomy. As you could see, patients that were older than 45, their overall recurrence-free survival was lower than those that were less than 45, where that difference in histologic subtype disappeared. So there are other things that also need to be discussed, because when I started the talk, I said it really should be viewed as a continuum, that not only one size does not fit all, or the crime has to fit the punishment. So one needs to consider the surgeon's overall complication rate. So if a surgeon has a permanent hypoparathyroidism rate of 7 or 10% with total thyroidectomy, perhaps that's a situation in which a patient with a solitary papillary thyroid cancer stage 1 would benefit getting a hemithyroidectomy. Some of you would argue then you need to go to a surgeon that has a better outcome, but that's not always possible. In fact, I think earlier I shared with you in the US, most thyroid operations are not done by specialized endocrine surgeons. So one cannot necessarily dictate that, but our healthcare is certainly going towards referring patients to providers with better outcome, providers sharing their data. But I think that's a very important consideration which might apply to Brazil as well. The other is the training of the individuals. Most of the specialized fellowships in endocrine surgery where individuals are taught and are able to do total thyroidectomy. There's been innumerable times where we've been referred patients who had total thyroidectomy for really high-risk papillary thyroid cancer, and the patient is referred to us. Why? Because there's a 2-centimeter remnant in the thyroid bed in a patient who had a total thyroidectomy. So I think the surgeon needs to be trained in doing a proper extracapsular dissection total thyroidectomy, if that's what we're going to call it. And certainly the approaches that one is using, I think we're going to hear about remote access thyroid surgery. I've seen robotic, I've dabbled in axillary approach robotic. It's almost nearly impossible, in my opinion, to do a total thyroidectomy using such approaches. I know Wing-Yung Chung very well, and even when you look at his data, probably has the largest experience with remote access or robotic thyroidectomy. Many of those patients have a remnant on the opposite side of the axilla that is used. Also, the intangible variable is that you need to be pliable, and that recognizing some of the patients, although preoperatively you think have stage 1 disease, might have more advanced disease. And then again, I think it's a team sport. It's not just a surgeon saying what procedure is going to be done. I have follow-up approach. I think it's the endocrinologist, or if you're working with a local internal medicine doctor, what they're going to be using for follow-up, and how the patient is going to do psychologically, and knowing their follow-up thyroglobulin is not going to be nearly as accurate with a remnant in place. I'll finish up with just 3 important points. I think papillary thyroid cancer stage 1 is a growing cancer diagnosis. I think for most patients that have a tumor then less than 2 centimeter, I would feel very comfortable doing a hemithyroidectomy. Again, I think this depends upon the patient as well as the follow-up one is going to be using. And I think if you have complete, reliable assessment of the preoperative staging, a hemithyroidectomy is very reasonable to consider. And certainly we should not be dogmatic on saying only hemithyroidectomy or only total thyroidectomy, because I think the data at best is equivocal. I'll finish up there, and thank you, and I look forward to any questions you might have later on.